Good afternoon. Thank you all for finding the time today to attend the webinar. My name is Brian Jones, and I'm a clinical program analyst here at AssureCare. Our company is passionate about the success of community pharmacies. Our topic today is medical billing for community pharmacies, preparing pharmacists for tomorrow today. Before we start, let me explain how you can communicate with us during this webinar. If you have any questions during the presentation, please just write them in the chat and I will be monitoring those. We'll have a Q&A session at the end to answer your questions. With that, I'm excited to introduce our esteemed speakers. First, we have Dr. Tara Fund. Tara Fund was the first PGY1 community-based resident in Oregon, Southwest Washington in 2009 through 2010. She maintains active engagement with local and national pharmacy associations, including co-founding the successful restart of the Southwest Pharmacy Association as vice president, and currently serving on the Washington State Pharmacy Association Board of Directors as the chair of the WSPA Community Practice Academy. Tara's practice area interests focus on optimizing healthcare for patients in the community setting via innovative clinical services and unique implementation solutions. Her background includes community pharmacy practice and community-based residencies, proof of concept of large-scale pilots of pharmacist prescribing models, which includes extensive national legislative requirement knowledge, and evaluation of medical billing and credentialing solution encompassing the unique challenges of pharmacists. Next, we have Dr. Kathleen McKnight. Kathleen McKnight is a board-certified nurse practitioner with experience in primary care, women's health, retail health, clinical operations, quality programs, professorship, corporate leadership, clinical pharmacy advancement, concierge care, and healthcare product services advising. She earned her Bachelor's of Science in Nursing from the University of Louisville, Master's of Science with specialty as a family nurse practitioner from the Ohio State University, and a doctorate in nursing practice from the University of Alabama. Dr. Kathleen McKnight believes in a simplified, holistic healthcare approach to helping people and populations on their wellness journey. She is passionate about creating innovative, multidisciplinary care models that drive optimal health and well-being. So welcome to our speakers. And with that, I will, with no further ado, turn it over to Dr. Kathleen McKnight.
Thanks, Brian. So today we're going to speak about clinical visit documentation and corresponding medical billing in pharmacy, specifically services and processes most applicable to community pharmacy setting with some crossover into the ambulatory care space. To align on definitions, community pharmacy refers to independent regional chains and mass merchandiser settings. Ambulatory care, on the other hand, is in the context of pharmacy, refers to pharmacists that are placed within a clinic setting, for which there can be a variety of settings. An ambulatory care pharmacist often serves in collaboration with a physician or other qualified healthcare provider, such as a nurse practitioner or a physician assistant. While traditionally, community pharmacists have really been focused on medication dispensing and education, and with a very, very limited scope in rendering clinical services, limited so much to like immunizations, biometric screenings, MTM or medical therapy management, medication therapy management, and the alike. Gradually, we've seen these pharmacies evolving into ambulatory care models where pharmacists are moving kind of further away from selling of the product and only selling the product to the realm of providing those essential primary care services to folks. We call these services clinical visits, or as Tara and I and the team like to call them, advanced clinical services. So advanced clinical services are offered by a pharmacy, and these can be offered independently under a state-guided protocol, under a standing order, or in a protocol in conjunction with a collaborating physician, as well as independent prescribing. Advanced clinical services being offered by pharmacists are and governed by state law include the evaluation, the screening, management, and treatment and so on, prescribing if applicable, and of an array of conditions from narcotic dependency with naloxone prescribing in the event of overdose to tobacco dependency, pregnancy prevention with hormonal contraception, flu, strep, COVID testing and treatment, TB screening, and several other acute conditions like urinary tract infections. It also includes chronic disease management, from initiating statin therapy in diabetics to providing chronic medication refills. To be paid for these services and be included as a well-rounded provider of care and payer network solutions, community pharmacists must have processes and technology in place to medically bill, which Tara is going to go into much more detail in a little bit. Clinical services with medical billing are important because, first and foremost, it increases access for care for our patients, which is so important. Second, it potentially captures higher recent reimbursement for traditional services like vaccines. And third, it creates an alternate revenue stream in a space where cost to fill margins are becoming tighter and tighter.
Well, that's very interesting, and it's clearly innovative for the pharmacy field. I'd love to pull Dr. Fund in on this. So how did you become interested in medical billing in the community pharmacy setting?
Well, Brian, it really for me started with my community-based residency program. As part of that work, I gained a lot of experience and exposure to what it took to design and implement and improve clinical services in a community space. I was practicing and still do practice on the West Coast. Oregon and Washington are my primary states. And so I've been fortunate enough, even back when I was working on my residency back in 2009, that pharmacist scope really wasn't my primary limitation to starting new services. I was able to teach and precept residents, students, and others. And along the way, while I found I loved innovative pharmacy practice, I also found that there were some components that needed to continue to be developed to really see this model successful. As I continued my career down the path of clinical program development in community pharmacies, I was able to really get to understand pharmacy law across the country and how various states have different processes, as Kathleen mentioned, to be able to support pharmacist provided services. And I was able to launch services in multiple states for things like hormonal contraceptives, naloxone, strep and flu testing and treatment, several regional pilots. In some areas, we did 22 or more collaborative drug therapy agreements. And I worked on all the pieces like policies and procedures, required paperwork for visit documentation, training of the pharmacist, how we were going to document this. And along the way, I really found that these paper-based cash payment model services were super motivating for the pharmacy team and had a great impact on the pharmacy team patient relationship and, of course, access to care. But as I said, along the way, I really found that there was a lot of opportunity of what we could also do to improve the overall provision of clinical community pharmacy. I continue to dream of a place in our profession where we say we provide clinical services, and that's first and foremost our basic component of our business model. And then dispensing is a sub part of that, which again kind of bounces off of what Kathleen said earlier. And I really came to realize payment was the key piece. There are a lot of factors that come into a successful project pilot, and I could do a whole talk on that too. But a growing body of literature is really showing that the lack of time for the community pharmacies to give those services, and then you couple that with no real payment model, that's really been a big barrier to widespread implementation and adoption of advanced clinical services. And while it's easy to say at first as a pharmacist, well, we don't have provider status, we can't get paid, it's really not that true. There are a lot of states that actually have provider status and payment parity laws. Some states commercial plans, others Medicaids, and this includes my home state of Washington, which was actually the first state to implement these regulations for commercial plans. I still remember it was back in 2015. It was Senate Bill 5557. I have it memorized. I remember when that was signed. And what it did is it required that all commercial payers include pharmacists as providers in their in-network roster of providers. And we really, really thought that this was going to be a time for change. I did too. But years later, we still just see pocketed implementation and success, especially if you're looking at the community pharmacy spot. So overall, Brian, what that did is it really started this mission to understand why, what's missing, and how do we get medical billing working in community pharmacies? How can we really integrate this into their business model? And one of the big gaps I found was when you look at pharmacists in clinic settings, unlike them, community pharmacies don't have that infrastructure or the departments that make it that they can just plug the pharmacist provider into. They lack the credentialing and contracting teams, the coders who train pharmacists on how to document for medical billing and how to select appropriate codes and make sure that they're reimbursed, they're not undercoding or overcoding, as well as patient relations if patients start having copays for pharmacist services, and revenue cycle management teams for medical claims, which is a completely different setup than PBM billing. So I really realized that along the way, if we wanted to see Senate Bill 5557 successful and in other states that have followed suit, community pharmacy really needed support and knowledge and changes. And luckily, I'm here living that journey.
You sure are, and you bring up a lot of great points there. Dr. McKnight, as a nurse practitioner and what we consider a little more traditional in this space, where do you see the documentation and medical billing main challenges for this new pharmacy landscape?
Yeah, sure. So as a quote unquote traditional healthcare provider that is forged a space, you know, you're right, I've been afforded the opportunity and experience to view those common state practices in the industry. And then over the past several years have evaluated best practices and as well as opportunities to transition pharmacists into that space. And these challenges that community pharmacies face in rendering advanced clinical service, you know, while it follows a similar processes, there are definitely a lot of nuances of the profession that you have to take into consider as well. So some of those challenges that are specific to routine processes and or applicable to the profession itself are the payer contracting, credentialing, and enrollment. This needs to be in place prior to seeking reimbursement and is really important. Then also clinical service eligibility. And this spans two major verification pieces. So first, you have the provider, if the provider is eligible to provide that service to the patient. And then secondly, you have, is the patient eligible under their benefits to receive that service? So those are all things that we have to consider. Additionally, is standardization of documentation. So standardization of documentation is required to appropriately identify the billable service at hand, accurately document the diagnosis and select those correct visit codes and or modifiers that may pair with it, and collate reportable data outcomes that will likely be required in some capacity as pharmacists forge in this advanced clinical service space. So one way to prepare for reporting functions that are likely in store for the future includes use of a certified EHR, or electronic health record for clinical visit documentation. While community pharmacists are able to submit claims today, namely vaccines and DME medical claims through medical intermediaries, the landscape of tomorrow is expected to look very, very different. Lack of revenue cycle management services is another challenge that I have seen and observed, particularly the management of medical claims, denials, and so forth, as well as software to support the billing, medical billing all in one platform. So that's just to give you a little bit of overview. Tara will go a little bit in more, but in general, pharmacists have been doing this work for years without compensation. And they lack the education or know-how, not so much the education, and quite frankly, the time to be able to close this gap.
Yeah, that's a wonderful point, and I'm sure many of our guests today would echo that in the pharmacy field. I'm going to shift gears just slightly. We all know that COVID's affected many aspects of our life and the healthcare landscape. So, Dr. Fund, what impact has COVID-19 had on this topic today of billing in the medical space for pharmacy?
Yeah, you know, honestly, it's been really fascinating reflecting back on the last couple of years in the space of medical billing in a community pharmacy, and really think about how the pharmacy profession has solutionized medical billing and how quickly they did it since COVID-19 rocked healthcare landscape. In 2020, because of the statewide emergency, the Department of Health and Human Services, or HHS, granted pharmacists widespread authority as at a national level that we aren't used to seeing. There was a lot of question, is this national level, or does state still take precedence? And all this was part of the PrEP Act, and it was really, really exciting. It started with COVID-19 tests and really quickly turned to expansion of vaccines, both in general as well as the ages that they could provide, the COVID vaccines and then pediatric vaccines as well. But what I saw really started to shift the landscape of billing and community pharmacies was that suddenly many payers, Medicare, uninsured or HRSA, and in some states, all of the Medicaid plans, the only way to receive reimbursement for the vaccines or tests that we were being asked to provide and enabled to provide was to be able to process payments on the medical side. And there was no alternative solution available. And it really meant community pharmacies had to figure out how to medically bill and quickly. And when you think about a little bit more foundation of the why, like why pharmacy can't medically bill, it's something we've had to answer for years in pharmacy. For years, I have memories of processing vaccines and getting back a rejection saying bill to medical and having to explain to the patient we are unable to bill the medical side. So when you start to look at those transactions in healthcare, when you're looking at a retail or community pharmacy, traditionally, all of our claims are transmitted, including vaccines or DME, as Kathleen had mentioned above, for payment, and it's all processed using this format called NCPDP D.O claims. And that is fundamentally different than the adopted standard format of claims for all of the providers, the health plans, the clearinghouses. And this historically has left community pharmacies in a silo. Everybody has to use one way except for pharmacy. And so it had pros and cons, but that con of not being able to process claims came to light very quickly with COVID. So less than 2 years ago, as Kathleen kind of just went through some of those barriers, I would have definitely put at the top of the list the inability to transmit out a medical claim. Now, pharmacies have new challenges in community settings. There are a lot of different products that have different infrastructures. They're set up fundamentally completely different. And suddenly pharmacists and pharmacy owners are having to figure out what's the difference and how to compare technology and what are the functional variances. They're having to think about what's the right solution now and what is the right business model for my future and what technology would fit my long-term strategy. So it's a lot of research, it's a lot of decisions, it's a lot of shopping that they haven't had to do in quite some time. So we'll continue to explore that a little bit more as we continue through our webinar.
Yeah, we certainly will. With that, I'll ask Dr. McKnight, could you discuss a little about what AssureCare is doing to address some of those challenges?
Yeah, AssureCare has a solution for pharmacies in the space. AssureCare's certified electronic health records allows for customizable workflows that cater to those very unique workflows in the community chain and independent pharmacy settings. Pharmacy workflows are vastly different from the traditional clinic visit or office visit in a primary care or other medical setting. AssureCare is able to accommodate these differences in the visit as well as integrate eligibility criteria and facilitate that revenue cycle management processing piece that includes the management of claims and denials and through the medical billing and payment to its actual client. So you may wonder what is different about AssureCare as many others are offering similar solutions. One of the main differences is that AssureCare provides a solution in a consolidated environment with MTM, pharmacist e-care plan capabilities, clinical visits, and medical billing all in one place instead of having to go into multiple applications, which is unique from many other platforms. Further, the consolidated application, it can potentially integrate with the individual pharmacy's dispensing system, adding an extreme time savings as well as an efficiency gain.
Yeah, that is a true benefit, I'm sure. And yeah. As we've heard how busy our pharmacists are. So Dr. Fund, now I have some inside information, and I know that you've had firsthand experience with this, leading a successful implementation of payment for tobacco cessation services in Oregon, and you used AssureCare technology. So I'm sure the attendees here would love to hear a little more about this process in the real world application. Do you mind sharing a little with us?
I would, Brian. It was an outstanding, really fun project to work on, honestly. It's a lot of detail, but I think it's a great story to tell, so I'll share it. In a nutshell, if I was going to summarize it, I would say what we did is we leveraged the tobacco cessation protocol that was passed via the formulary committee legislation in Oregon, and the local university's relationship with the Oregon Health Authority, which is Oregon's public health agency that oversees the Medicaid programs. And using all of those pieces and AssureCare, we were able to implement a new compensated service in independent pharmacies in rural Oregon for tobacco cessation prescribing services and bill for them. Whenever I talk about medical billing in pharmacy, as I have today, and I do if you've ever had any other conversation with me, I always talk about you've got to support this process from start to finish. So I'll go through each step a little bit in more detail now, just to really paint the picture and some considerations and learnings I've had along the way. So as I mentioned, there was the partnerships with Oregon State University College of Pharmacy, or Oregon State, and the Oregon Health Authority that were leveraged to fund some of the aspects of this project we were able to work on, including state-sponsored training for tobacco cessation services in Oregon for the pharmacists. They also saw a gap and an opportunity for the marketing and awareness in the general public, so they supported some campaigns there, as well as the partnership with our software company to really support the pilot of those independent pharmacy locations, really getting off the ground and getting started and having claims transmitted. In other projects I've worked on, other stakeholders could be physicians in states if you've got that collaborative practice agreement model, or maybe a protocol that requires a physician to sign off. And also state pharmacy associations, which often support pharmacy implementation of services and payment for them. So once the core partnerships were established, the next thing was the pharmacy teams had to be trained on the various services. So this included considering a clinical knowledge refresher for the clinicians, looking at the state protocol requirements and making sure the pharmacists were aware of the service provision mandates, and then really looking at those company policies and procedures and making sure that the training included implementation pearls, getting the staff engaged and spreading word of mouth. We also made sure that pharmacists had training that was focusing on selecting ICD-10 codes and billing codes, things like evaluation and management, or E&M, things that many pharmacists didn't learn in school, and really making sure that they felt comfortable with the robust charting requirements that come alongside medical billing. But I would say, and I've already said it a couple times even today, that equally important to training on the software and the workflow is we've got to make sure that the local providers and community members know to view pharmacists as a place for care. As our scope continues to be offered across the country really by pharmacists and pocketed availabilities and kind of varied practice models, what it leads to is this gap in understanding in the public of what can community pharmacies do. If one pharmacy does this and another does this and some say none, it's hard for the public to really rely upon community pharmacies as a place of care and to really start viewing them as a place to receive something other than safe medications being dispensed. So that's something we're definitely working with the Oregon Health Authority and the College of Pharmacy and various marketing companies and tactics and tools to keep getting the word out there in Oregon. Up next on the docket, and I would say in some ways you start here and keep it parallel, would be that credentialing and payer enrollment piece. Mm-hmm. It can be really time consuming. There's a lot to learn and a lot to do. In Oregon specifically, what we did is we looked at the straight Medicaid plan and made sure that we were able to get the pharmacist set up there. So to do that, we had to update the primary taxonomy to be pharmacist clinician. And then there's state paperwork that you have to complete, enrollment paperwork, and you complete all that, and there's a processing time. And on the other side of that, they receive an Oregon Medicaid provider number, or often called a DMAP ID or DMAP number. We then worked with the coordinated care organizations in Oregon, which we typically call CCOs. Most all other states that have this setup called an MCO. But we started to work with the CCOs to really clarify what the credentialing and enrollment requirements were for payment in the community pharmacies by them, because it's CCO by CCO, very similar to commercial payers, it's payer by payer. So what we found is that the requirements were varied. Some of the CCOs really permitted and preferred out-of-network claims for pharmacists with a DMAP number from the Oregon Medicaid. They kind of deferred to that enrollment process, especially as these services were just being started. But others started to say, you know, let's look at being in network, and how they wanted to bring pharmacists in network was also varied. Some went with the traditional direct credentialing of the pharmacist using the state practitioner applications, which is the most traditional way. But others had a hybrid pharmacy-facing facility credentialing model, which really helped support bringing a lot of pharmacists on in network to serve those CCOs patients in an efficient manner. But doing that model does require development of new processes for the payer. So lots to learn and work on there. And so while that's kind of underway, again, it takes 3-6 months, sometimes longer. We really turn to looking at the workflow of the software being used. So as Kathleen had mentioned, it's our ONC certified iPatient Care electronic health record. And really said, pharmacies are busy. We know that they're not providing services first and foremost. They're primarily dispensing. How can we look at workflow tools to make this user-friendly? So we made a comprehensive user manual and then a quick start guide. So that way, when they sit down to see that first patient, they've got a 2-pager they can pull out that just tells them click by click what to do. But then they've also got the details of the details if they so desired, in addition to training and other support, of course. We also, especially with my years of implementing services in community pharmacy, made sure to look at the workflow and making it user-friendly for the pharmacy team. They have to be willing to do the service. That's a core piece for sure, I've learned. So some of the things I did was I made sure that we took those state requirements and built them into the configuration of our software, so that as they study the Oregon protocol requirements, they can be confident that they're following that guidance as they see those patients, and have it be integrated, for example, the patient intake form into the electronic data collection. So it's all becoming part of the electronic record. We also looked at using the JCPP, or Joint Commission of Pharmacy Practitioners, patient care process. It's well documented. Most pharmacists are very familiar with this model. It's really applicable to all practice settings where pharmacists provide patient care, and also really applicable to all patient care services provided by pharmacists. And so we've configured our EHR to follow that collect, assess, plan, implement, and follow up, which is really that friendly model of care delivery that pharmacists are used to seeing, and really is in line with national recommendations for pharmacy patient care services. Other things we did was think about how we can make direct access to national guidelines or state treatment algorithms right there in the visit, and support role-based tasks. So technicians practicing at the top of their license alongside pharmacists, and really being engaged in these advanced clinical services, as that is a gap I've seen historically. And so we really teed up the visit flow to optimize that. And finally, we were able to integrate local provider directories for the locations of the pharmacies based on the NPES, and enabled automated electronic communications with the patient's healthcare providers using templates and automatically populated fields based on that patient encounter. So these were all things I only dreamt of having when I was doing paper-based implementation. So it's really exciting to see it be live. Once the pharmacists were finally set up with those payers, the last component was to really set up the real-time eligibility checks and really make sure patients are actively covered by the payers prior to rendering that service. And so we did train the pharmacists on that. Then it really became a matter of the first patients walking in the door. They can be seen as walk-in or by appointment by the pharmacist for those tobacco cessation encounters with follow-up. And if those patients are covered by a payer that the pharmacist is set up with, the medical claims clearinghouses will then process that transaction and transmit out the medical claims to the payers after that documentation is complete. So then finally, again, I know it's a lot, but it's great stuff, I think. The revenue cycle management component that I know Kathleen hit on a little bit, it's that last step to really confirm that the pharmacies and the pharmacists are getting paid at the contracted rate in a timely manner. So after completing setup, so it's things like EDI, ERA enrollments, claim setup, EFT, direct deposits, tons of fun stuff. Then the RCM services support clean claim transmission based on an ongoing basis based on those pharmacy services being provided. And they also follow up on every one of those claims, handling rejections or denial managements and confirming funds were deposited as anticipated down to the penny, which with pharmacy claims, billing claims from a pharmacy location, there are some hiccups because it's so new. And so we're right there alongside you to help make sure that this is really set up all the way down to the payer side, right there alongside you. And another thing I just like to call out is that revenue cycle management services are really important to start thinking about now for community pharmacies. Because similar to credentialing and enrollment or medical coding documentation requirements, most community pharmacies haven't really had to start thinking about some of these processes that come into play with medical claims. Two core pieces would be copay collections, collecting that way down the line, 2 months later, realizing the patient owes you $25 or $45. We've all received those bills in the mail from our physician's offices, but we are not used to seeing those from a pharmacy. And how would that process work? As well as really starting to think about how we can have the traditional practice setting continue to be supported as we expand and make sure that the medical claims payments are being received. So it's been a fascinating component to explore further in this project. I really hadn't understood all those intricacies of claims follow-up. And so really exploring that has been pretty rewarding for me, I'd have to say. So hopefully that was good background. We started with the partnerships and the training, the credentialing and enrollment, and we ended with the workflow tools, processing of the claims, and the revenue cycle management. And it was a journey, honestly, to get the pharmacists paid, but it was fun, a lot of learning. And I think the best part is that in the end, all this work, all this setup work for a service and a batch of payers can quickly and easily and efficiently be expanded to more services and more payers because all the foundation has been laid. So it really does get easier and easier to grow this exciting model of patient care.
That's wonderful. And there's no need to apologize for the length. I know we could probably have a presentation on each one of those sections of that project. It could be hours long. So thank you for that summary. And I'm going to pull a little piece out of there. I noticed Dr. Fund say something about an ONC certified EHR. Dr. McKnight, could you elaborate more on what that means and why it might be important in the pharmacy setting?
Yeah, absolutely. So presently, pharmacists remain one of the only healthcare providers involved in disease management and patient care who do not have full provider status at the federal level. This limits their ability to get reimbursed for healthcare services provided to their patients. In my opinion, that's going to change. It's just a matter of time. And I think that time frame may have just sped up pretty significantly, given that community pharmacists served as a major role in effectively screening, identifying, and vaccinating folks in the pandemic. But in preparation for provider status and implementing an ONC certified EHR, or electronic health record for clinical visit documentation, can prepare the pharmacy to accept reimbursement from Medicare, or all government payers and commercial payers as well. So back to your question, what is that ONC certification? So as it says, as you see on your screen, it's a bit of a mouthful. It's the Office of the National Coordinator of Health Information Technology, and it's located within the Office of the Secretary for the Department of the United States Department of Health and Human Services. So say that 5 times fast. And the ONC is the principal federal entity charged with the coordination of nationwide efforts to implement and use the most advanced health information technology. So when it occurs, when federal provider status occurs, pharmacists will rank on a new list. And that list will be on a list of other qualified healthcare providers, which includes nurse practitioners, clinical psychologists, registered dietitians, and so forth, that are eligible and over time may be and are likely to be incentivized or penalized under select circumstances to report quality measures under the CMS Medicare Quality Payment Programs parameters. So to become an even more integral part of the care team and provide continuity of care through the advanced clinical services and get paid fully, they need to potentially, they can meet interoperability standards and get more revenue if they meet those minimum requires as they evolve. So, at minimum, ONC certification too provides a standardization. So even if they're not held to all of those QPP line items, it provides that standing reporting fields to prove the outcome of care, which we know with value-based in the forefront will be so important to continue to prove the value and cost effectiveness of utilization of the pharmacy. There's a great post that's going to be, I think it's on the last slide of this presentation, that I recommend everyone take a peek out. And this outlines this whole discussion on ONC certified platform and community pharmacy. Brian, our moderator and colleague, did a wonderful job on this article, and so it's definitely time well spent on a great read.
Yeah, there is a lot of buzz around this and conversation, as Kathleen brought up, especially as we were researching it. So, Tara, why do you think this is so important right now, and why it's emerging so quickly?
Yeah, I mean, there's a lot of points that we've brought up today, Kathleen has brought up, and have set a great foundation of the timeliness of this topic. But I think it's important to note that even prior to the pandemic, leading up to it in the last couple of years, there's been a lot of exciting movement and legislation regarding specifically pharmacist scope. We were seeing a lot of bills being introduced at rapid rates, a lot of them around specific services, birth control prescribing, naloxone, tobacco cessation, travel medicine. And some were going with this broader criteria, saying pharmacists can assess and prescribe and potentially treat medications around any condition that requires no diagnosis or is easily diagnosed or self-limiting. So if you think about it, pharmacists really have been helping those patients in that kind of capacity for years with minor ailments and acute needs. But it's been limited to over-the-counter recommendations or referring them out for care. And so they just gave them one more tool in that toolbox. But in this last year, the inability for pharmacists to bill for services already within their scope and things that they do every day, even if they don't have prescribing status at all. Think medication management, management of chronic conditions, testing and treating, screening, vaccines, transitions of care. The list goes on and on. Patients care for patients. They do billable services every day, and they're not being compensated for it, as Kathleen said at the beginning, and it's being increasingly recognized across the nation. We have seen a handful of exciting wins about payment for services slowly and steadily taking place really recently too, that really mirror that success we were lucky enough to have in Washington a few years ago. But even more exciting, earlier this year, the Pharmacy and Medically Underserved Area Enhancement Act was introduced, and it was supported by national and state pharmacy associations. And what it would do is provide the reimbursement to the pharmacists who deliver Medicare Part B. And if they're already authorized by the respective state laws, they can provide that care with an emphasis on underserved areas and populations. So this is especially exciting. It would be a huge first step of many, but it would help us align reimbursement for pharmacist services to match the quality care that patients receive from these community-based settings, and really ultimately expand options and access to care. So all these changes and wins are really important as the profession of pharmacy moves along in this adventure to get paid, as I like to call it. The need for more knowledge and support with each of these steps that I went through in the Oregon project, for example, starting with that provider-patient relationship, ending with actually getting successfully paid claims to the payment at your contracted rate, alongside a long-term medical billing solution like a certified EHR that really level sets you on that same playing field as other healthcare settings as community pharmacies. The need has really never been greater. Time is now, Brian.
Yes, you're right. And yeah, that really brings to light the relevance of the topic right now and why we're hearing so much about it. So Dr. McKnight, with the AssureCare product, what is your thoughts about future use cases and how that could advance community pharmacies?
Yeah, AssureCare is doing some amazing things. Among its diverse suite of healthcare products and services, AssureCare currently carries a product called MedCompass, which carries a medication management module for pharmacies, as well as they also have the certified electronic health record to support the clinical visit and billing piece. This bundled solution, all-in-one-place solution, is a differentiator in the model. AssureCare also offers consultative services for from the clinical service setup to pay enrollment, to claims transmission, denial management, and payment to offer that smooth transition. So we kind of do a bit of a hand-holding, as Tara referenced, to make sure everyone gets paid. And then also, AssureCare does more than just post a training or do live webinar orientations. We have people that really understand and are experts. They really get the intricacies of, throughout the entire implementation and onboarding process. The company can also service as a total solution, taking care of the entire insurance submission process, through the payment output. So we've mentioned several times that RCM, or revenue cycle management piece, that I previously alluded to, that just that pharmacies really have not had too much experience in the medical capacity. AssureCare is working on some incredible innovative projects in the space as well, from continuing to strengthen our current user experience in the application to actually evolving it. Oh, sorry, I got a bit of feedback there. To evolving its pharmacy service eligibility through state criterion and integrating that into our platform. Without exposing too much of all of our innovation, I will say that AssureCare really truly aspires to continue to be on the forefront with solution differentiators in pharmacy, as that profession, pharmacists keep rapidly evolving, and healthcare provision. I look forward to all that is in store for the profession of pharmacy, and being able to support community pharmacy and being a solution to the current healthcare crisis in America.
Thank you, Dr. McKnight, and I fully agree. Great things are to come, and AssureCare is ready to help our partners with that. So with that, I'm going to thank everyone for the attention so far and the engagement throughout this presentation and on this topic. We already have a few questions that have rolled in, so I'm going to check the chat. But if you guys want to continue to engage in conversation, you can feel free to type your questions in that area. So let me check that real quick, and I will see who the lucky winner of the question is to answer it. Okay. Our first question, I think this would be appropriate for Dr. Fund. As pharmacies are having to reinvent their business models to support high prescription volume with decreased reimbursement rates, how difficult is an implementation like this in a busy pharmacy? Great question.
So true. Yeah, absolutely great question. Especially because not only are they, looking at implementation in a busy pharmacy, but they're also looking at learning about medical billing, documenting in accordance with medical billing, which is very different. Some services like vaccines, they can be billed on the medical side, where you never seemingly lose that dispensing software. They're billed that same way that the medications have been done for years. But when you look at that expanding pharmacist scope and advanced clinical service model, it's really important to really start thinking now to that great question about how we could document those encounters as part of that new pharmacy workflow. So some of the things I think about, one of the things I talked about is with the Oregon pilot, was to really look at making workflows simple and intuitive, so that the pharmacy teams are willing and able and engaged and have the tools at their fingertips, like the quick user guide. Is really useful to be able to just have that cheat sheet of how to do it. The role-based task is also huge, I think. Having the patient information and the intake information documented in advance with core pieces for the pharmacist to review and assess prior to moving on into the full assessment of that patient. That really mirrors, if you think about it, what you would see if you take your kids to the pediatrician or if you go see a physician's office. And it also gives that benefit of the chunked workflow, which in my experience can be really helpful. The pharmacy team can successfully toggle between doing patient care and medication dispensing relatively easily with you breaking up the workflow pieces, using that collect, assess, plan, implement, follow-up model, and engaging that whole team. Another thing that comes to mind is being flexible with the documentation. There are some pharmacists out there in community settings who are really ready and looking for that singular EHR that can accommodate robust, all-encompassing, full workup patient assessments, complex in nature, maybe an hour long even, where they're addressing a ton of diagnoses, ICD-10 codes, maybe they want to do time-based billing, and maybe they're leveraging CPT modifiers. But then there's also a lot of pharmacists in community settings who are looking for this streamlined, simplified, templated workflow for things like birth control prescribing or tobacco cessation. And so one of the nice things about our software is it really is able to support both setups and really be customized around that team and the services. Another thing that I think about, looking ahead as these services become mainstream is the benefit of a paperless process when you're using an EHR. So company audits, board of pharmacy audits, payer audits are all things that may or may not happen today, but undoubtedly will be in the future. And when you're using a certified EHR, you can have that audit be done remotely, even without a site visit often. And that can be a huge time saver down the line. So that's kind of in some ways futuristic, but a huge one as well, I think. Then there's a lot of pearls that come to mind of training teams, again, just from having launched the services. But those are some things like really applicable to the setup and the design of the visit flow that come to mind. I know those pharmacists, we love to care for patients, and it's a matter of having those right tools in place and marrying those things together. It's going to only be a matter of time until we can get to that point where service provision is really commonplace and the volume expands, and documenting and providing patient care services is normal, kind of like what we saw shift with vaccines. Those are normal now. Being able to medically bill for clinical visits will be normal in pharmacy, and I can't wait for that day.
I know you can't. So, thank you for that. And we did have another question here that I think really aligns with a topic you broached earlier, Dr. McKnight, and it's how is AssureCare different from the other solutions that are on the market?
Yeah, sure. Thank you. So, previously we talked about the consolidated environment with MTM or medication module and clinical visits. So we have that total solution. Many solutions today in the market that we see are offered as what we call medical intermediaries, meaning they're that conduit that enables medical billing. Presently, the vast majority of medical intermediaries in the space, they don't have that infrastructure to support a certified electronic health record capabilities that will likely evolve over time and include requirements with the advent of the federal provider status of pharmacies and pharmacists. So AssureCare offers those clinical visit workflows that we discussed, the medical billing, the revenue cycle management tailored to pharmacist needs, and they can meet every need around those current service offerings and easily transition into the billing and reporting needs of tomorrow as well. Also, AssureCare brings clinical visit templates for pharmacists for their prescriptive authority beyond just the services of today, so the vaccines and the DME. And lastly, I'll just do a quick mention again about the knowledge and know-how and expertise for things like payer credentialing and enrollment that really we can bring as a company from an end-to-end to help those consultative services and expertise as you implement and onboard these services to your pharmacy.
Great. Well, thank you, and thank you to our guests for the engagement and the questions today. It looks like we've addressed all of our questions for now. Dr. McKnight, Dr. Fund, is there anything else that you'd like to mention before we go today?
I would just like to say I have been on this journey with Tara in one capacity or another for over 6 years, and she's been on it much longer than I have. But we're at a pivotal moment, and things are moving fast and picking up. And I am just, this is such a good thing for our patients and the general healthcare landscape. And I can't say enough. I'm excited to see where it goes.
Yes, that's wonderful to hear. Thank you to you and to Dr. Fund for this just great information today. And to all our guests, if you'd like to learn more, on your screen, you'll see Emily Vance's email, and we're just an email away, and we're happy to discuss how AssureCare can help your pharmacy prepare for the future of medical billing. So we thank you for participating today, and we definitely hope to see you again next time. Thank you.